at the Surgical Cave Hill School of Business and Management, located at the University of the West Indies Cave Hill campus, we meet the needs of the upwardly mobile professionals. Our business school functions in an evolving global space where the need to have that competitive edge distinguishes you as a professional. Our academic curriculum offers a variety of programs that gives you that edge. We offer our students a doctorate in business administration. Then, there's our executive masters in business administration. Our Surgical Cave Hill School of Business and Management is for you. Enroll now.
Okay, good evening all. I want to give you a warm UWI Cave Hill campus welcome to our second edition of our panel on debunking the myths surrounding the COVID-19 vaccine. We had initially planned a single session, but we were unable to take a number of the questions last time. So we decided, given the high level of interest in the topic, that we would reconvene. On our panel today, we have Dr. Joy St. John again. She rose in the ranks of public health in Barbados from 1994 to become the first Barbadian Chief Medical Officer of Barbados in 2005. She also represented Barbados on the executive board of the WHO and became the first Caribbean person to chair that board from 2012 to 2013. July 2019, Dr. St. John became the executive director of the Caribbean Public Health Agency, so-called CARPHA. There she steered CARPHA through a CARICOM evaluation, selected new directors, improved the governance and accountability frameworks of CARPHA, as well as focus on strengthening CARPHA's resource mobilization and partnership portfolios. We also have Dr. Michelle Reese. Dr. Michelle Reese is an assistant professor in the Department of Public Health, College of Health and Human Sciences at Western Kentucky University in Bowling Green, Kentucky. She teaches courses in international healthcare, healthcare systems, public health administration, healthcare management and policy, and strategic marketing and management of healthcare organizations. And her research focuses on health equity, community and behavioral health, and minority health with a special interest in refugee and immigrant health. We also have Dr. Karen Broome. Dr. Karen Broome is a physician and public health practitioner who has worked in the Ministry of Health Barbados for 21 years. In April 2020, she accepted an assignment with the Pan American Health Organization, PAHO, as the advisor immunization for the Caribbean sub-region. During this time, she has assisted countries in the region to strengthen national immunization programs in the context of the COVID-19 pandemic and the introduction and deployment of COVID-19 vaccines. And last, but by no means least, we have Dr. Kenneth Connell. He is the Deputy Dean for Internationalization and Recruitment, the Faculty of Medical Sciences at UWI Cave Hill. He's a lecturer in clinical pharmacology. He's a member of the University of the West Indies Senate, which is the highest decision-making committee of the UWI. And he also serves as our public orator. He's a director of the Healthy Caribbean Coalition. He's a governor of the American College of Physicians, Caribbean chapter, and serves as a consultant internist. So we have a very capable and exciting panel here for you. Now, as we introduced this issue last week, I would have shared with you what we call the 6A model. And one of the things we want to emphasize is that a successful vaccination program requires a comprehensive and overarching view of vaccination. Vaccines need to be available. They need to be administrable. They need to be accessible. They need to be acceptable, affordable, and then we need accountability, especially in the fact that most of these vaccines require 2 doses. So we're going to start this evening, and I'm going to ask Dr. St. John to speak first and particularly talk about the issue of the availability and accessibility of vaccines in the Caribbean region, given her unique positioning at CARFA. So I want to turn it over to Joy as she goes first. Thank you.
Thank you very much. And let me see if I can share my screen. Let me know if you are seeing it. And if it's
yes, we're seeing your screen, so you're on screen, yes.
So thank you so much for this opportunity. And notice the pictures that I have put up first. And we're talking about debunking the myth of COVID-19 vaccine. And I start with this governance slide because starting from Honorable Mia Motley, these three persons going over to the left have been the chairs of conference of the heads of government who have steered the Caribbean region through this pandemic. And we are currently being led by the Honorable Keith Rowley. And before that, we had the Honorable Ralph Gonzalez, who now sits on the Security Council the United Nations. And extreme right is the Honorable Prime Minister for St. Kitts, who sits on the steering committee of the overall ACT Accelerator, which seeks to ensure access of the whole world equitably to vaccines and treatments for COVID-19. So there has been regional solidarity and advocacy. And in this whole quest for access, there must be funding. And CARFA was lucky to have a pot of funds from the EU for several things to do with supporting the member states in their fight against COVID-19. And we had over 2 million, almost $3 million US dollars put aside for treatments and vaccines. And so we supported the down payment of member states to enter the COVAX, which is a facility that has over 190 countries that allows persons access to vaccines. We've supported 9 of the member states who are self-pay, and we have money put aside for the 6 who are going to have concessions. And you can see that we're talking big bucks for the Caribbean to support the vaccination of 20% of the population. But we've learned now that we need much, much more. And so in regional solidarity, there have been efforts to procure, and we've got donations sent to Dominica and Barbados, and they have been sharing vaccines with the countries. And if you look at the pictures, you can see even Prime Minister Chastanet of St. Lucia receiving the vaccines that were distributed by the RSS. But there is this thing called acceptance. And there has been a lot of vaccine hesitancy. So CARFA has mounted a survey to understand what are the things that people are worried about so we can craft our communication messages. And when I say we, it's not just CARFA. For our 26 member states, we have regional health communicators network. So there's going to be a concerted effort. And the leaders have shown the way as well. So you see the 3 prime ministers and Minister of Health of St. Lucia, and also on the right, 2 chief medical officers leading the way as they receive their vaccines in the Caribbean vaccine drive. So what vaccines are available, approved and pending? CARFA recognizes 6 authorities, WHO, US FDA, Canada, Switzerland, the EU, the UK. I think I've covered all. And we have had Pfizer, Moderna, AstraZeneca from the Serum Institute of India and the Korean sites. And I just got word that FDA has approved Johnson & Johnson's 1-dose shot this evening. And we have several other vaccines in the pipeline. Sinopharm from Beijing, Sinovac also from Beijing, and Sputnik has been accepted for assessment by WHO. And we want member states to ensure that they have approved vaccines, ensure that the vaccines that are being purchased are the ones that have been approved, because we've had bogus vaccines in the Americas region, and share reports of adverse events or falsified vaccines. But we also have something else in the mix, and it's the fact that we have variants that have entered our region. We've been searching for the variants from Brazil, South Africa, and the UK, and at least 5 member states have had the UK variant detected. This is CARFA in collaboration with the University of the West Indies St. Augustine campus. So we have learned here in Barbados, and we are learning around the Caribbean and around the world, that we need to be protecting a nation with vaccination. I'm very proud of this fact that on the 25th, Barbados surpassed 25,000 persons vaccinated in just about 2 weeks. That's an amazing feat. And we look forward to that access, not only getting the vaccine, but having the systems to vaccinate and having people interested in getting the vaccine. Thank you, Chair.
Okay, thank you very much for that. And while you are on the floor, so to speak, I just wanted to get a couple of points clarified and some questions. So in terms of vaccinating the region, the Caribbean, to the level that we need for herd immunity, what is the approximate price tag for that? If we were to vaccinate, the cost of that, because I saw one of your slides, it was 80 million US.
Yes, and that included the cost of the vaccination drive itself, not just the purchase of the vaccines, but that was just for 20% of the population. There has been no clear percentage identified as that which will get herd immunity. I would want Dr. Broome to speak to this, but we've heard a range between 60 to 95%. And so if you extrapolate that, it's a lot more funding that is required to really make sure the entire process, the purchase of vaccines and other, like the syringes, et cetera, and employment of persons into the process is going to be quite a hefty sum. But it's the way of allowing us to get back to the new normal.
Right, so just to be clear, so the best estimate that we have is that to vaccinate 20% of persons across the region is going to cost us about $80 billion.
That was at the time when the vaccines were $10.50 US a dose.
Right.
But I believe that because we've been able to get 190 plus countries in COVAX, that those prices will come down. So I am hoping that we get those vaccine costs right down. I'm not sure about the deliverables,
right? So if we work
equipment and so let us say, for the sake of argument, 80 plus another 80.
Okay, so let's work with the 80 million figure since we have that. What's the funding strategy across CARICOM in terms of raising that 80 million? And how much do we have? What is the state of the funding gap? And what's the strategy for sort of bridging that gap? Can you speak? Is that something you can speak to?
I can speak to some of that. So CARFA has supported several member states and can support 6 more for the down payment for vaccines. We have also, when I say we, this is CARICOM Secretariat, and this is a specific mandate from the heads. CARICOM, CARFA, and PAHO have also been mandated by the heads to support with resource mobilization. So we've been having a lot of outreach to several entities, a lot of countries. And also there has been already, we've seen donors. So there is already that perspective. And of course, we heard the Prime Minister of Barbados make an outreach to the private sector.
So would I be correct in saying that in terms of having vaccines available to citizens across the Caribbean, there are 2 issues I'm hearing. One, actually getting access to those vaccines, because we heard Prime Minister Rowley speak very clearly about richer countries sort of grabbing the supply. So that's one issue. But also, even if they were available, that we would need, that there's still an issue in the region in terms of having the funding available to acquire those vaccines.
The funding, I don't think you need to worry about. The recognized funding agencies have been working closely with individual member states and at the CARICOM level, and the various platforms, because there's also the Africa Medical Supplies platform. The various platforms have also come through with arrangements through their banks. So we have our tried and true people like the IDB, World Bank, who have made arrangements individually, and we are also working with them at the regional level. And we also have the national funding, we have the donor support, and we have the private sector.
Okay.
By hook or by crook, this region is going to be vaccinated.
Okay, so we are looking at a funding gap, you would say then, of what, about 60, 70 million US at this time that needs to be raised to ensure that
that is in the process of being raised.
Okay, that's in the, okay, good. Now, before I let you go initially, Prime Minister Rowley.
You better ask me a public health question, no.
Okay, but I wanted to know if you could comment a little bit on getting the actual access to the vaccine, given this, what people term vaccine nationalism. Is that something you are comfortable making a comment on?
Well, I started already in talking about the Honorable Timothy Harris of St. Kitts and his position on the ACT Accelerator, where he can advocate for us at the very highest level. I also referred to the position of the Honorable Ralph Gonsalves on the Security Council. I am aware that both of them have made outreaches. And then there is this whole issue of the solidarity within the region for procurement. And we have made some really good alliances with the Africa Medical Supplies platform and with individual countries like India. So the access and the advocacy for that access, I feel very comfortable with. And we are also, as you've mentioned, the statement that came out from the heads of government meeting just concluded. We are also looking further. Further as in other countries not mentioned, but not far away, because they're still in our region.
Okay, thank you very much. Now, to give us a broader perspective on various aspects of a successful vaccination program, I'm now going to turn to Michelle Reese. She's in a kind of unique position, a Barbadian in the United States working in public health, so quite aware of a lot of the issues around. Michelle, it's all yours. You're still muted, Michelle.
Thank you. I'm happy to join you again today. I have a PowerPoint presentation, and but I'm only going to use about 2 or 3 slides. I'm going to share my screen. Give me one moment. Sorry. Share screen. Tell me when you can see my screen. Okay.
Yeah, so it is on screen, so you can go ahead.
Okay. So, you know, we talk a lot about vaccine hesitancy, and as I mentioned in our last presentation, that in addition to hesitancy, we also have to talk about confidence and getting people to move from, I don't want to get it, to at least I'm going to think about it, and then start making decisions to get it. One of the things that we have to show them is that there are people who are confident in the vaccine, they have accepted it, and they are ready to go. But one of the things that is required in creating vaccine acceptance is we have to build trust, transparency, provide tailored vaccine information. There are lots of vaccines out there, but when it comes to the specific nation state, people want information on the other vaccines as well, but tell us and educate us on what is actually available. I mentioned all of this, normalize fears, address their concerns and questions, but the bottom line is vaccine saves lives, prevents severe disease, and we need to do it. One of the issues is that there are still many healthcare personnel that are not on board with the vaccine. And to promote confidence, one of the things that we have to do is get the healthcare personnel on board. Get the vaccine and recommend the vaccine to your patients. This is nurses, doctors, and any of the other allied health professionals. We can use your local organizations and associations to reach out to their members and make it a drive to stay alive kind of thing in our organization. But we also have to make sure that, particularly the allied health professionals, that they also have the kind of information that they can share with their patients. There's nothing wrong with a podiatrist talking to that diabetic patient about the vaccine. But typically we can stay in our silos and leave that information to who we think might have more information to share it. But hesitancy, no information, misinformation, and disinformation. Misinformation is you're not getting it right, but disinformation is information that is deliberately used to mislead people. And this is where the myths come in, and we'll talk some more about the myths regarding the vaccine. For example, if you eat garlic, garlic will protect you from getting infected with COVID-19. That is not misinformation, that's disinformation. All right. And there's confusion too around some other things. We talk about how rapid the vaccine was developed, and I think we addressed that really well on Monday. But again, this is not something that we need to worry about as much as, or the effectiveness versus the efficacy, as much as some of the other things that really stop people from getting vaccinated. Side effects versus adverse effects. And Dr. Connell is on a panel, and perhaps he can talk a little bit about the difference between a side effect and an adverse effect. If you get diarrhea, that might be a side effect, but what would be an adverse effect? And so sometimes people are using these terms interchangeably, and it can lead to some misinformation. I also talked about the A's as it related to access to vaccines, availability, and within when we get it and how we roll it out, affordability, cost to the consumer. Even though we don't have to pay for the vaccines as citizens, cost is not just about the dollars and cents. Cost is about what else it takes to get the person there to be able to take that vaccine. Appropriate, does it meet the needs of various groups? Who qualifies and when? Is it acceptable to the person's perception, the disease risk level, versus the level of discomfort of getting the vaccine. So we know that COVID-19 can cause severe disease and death, and we know that the vaccine will cause or can cause a person to have some mild side effects or some moderate side effects or even severe for a few days. And then the points of dispensing, is it acceptable? Clinics, I noticed that Barbados had a drive-through used in schools, and then what about in homes for those who can't get out? I think Dr. St. John talked about advocacy and minimal to zero barriers to obtain the vaccine is what we are working towards. I think that I have these 3 words on there: relay, educate, and communicate. And I just want to spend more time addressing the specific questions that our audience may answer.
Okay, so again, so thank you very much for that. And as we move on, so we'll come back to some questions for you. I now want to invite Dr. Connell to give his perspective, and he's a member of the vaccine task force here in Barbados, and he's also a practicing physician on the front line as well as being an academic. So Dr. Connell.
Thank you, Prof. And I'm going to share my screen if Michelle allows me. Great, thank you. So this evening, I wanted to focus in on what I consider some of the science of vaccinating that might cause some problems. I started last time by saying vaccines are special interventions. They're given to a large population. They're given to healthy individuals, and their effects are meant to be long-lasting, and therefore the fear of their side effects and adverse effects are also thought to be long-lasting as well. But here's some of the rigor that clinical trials that around vaccines are put to. So for instance, we know that vaccines have not had a clean history. We know that many of our people who look very much like us have been abused in these clinical trials. And therefore we know that science is not always trusted, especially as it relates to vaccines. However, vaccine trials are basically in 3 phases: phase 1, phase 2, phase 3. They're really just addressing 2 questions. Is this vaccine safe? Because regardless of how effective it is, if it's not safe, it can't be used. And does it work? So is it safe and does it work? The phase 1 and phase 2 trials really speak to safety, especially phase 1. And then phase 3 trials answer the important question, does this thing work, or is this just water that we're injecting? And therefore the term efficacy comes up. Is the vaccine efficacious? The trials that speak to this are really very simply designed. You either take the vaccine or you take a placebo. And based on a set outcome, whether for instance you get severe illness or a hospitalization or even death, we then compare the 2 groups and we give efficacy. So bear in mind, efficacy comes from a clinical trial. These are specially designed environments, selected patients, they're monitored under different conditions, they're usually selected populations, and efficacy is given. So you have, like for Moderna and Pfizer in the 90s, and for AstraZeneca, for instance, in the 70s. And then comes the real world. How effective is this drug? We know it's safe, reasonably. We know that it works. What is the effect that it has in real people? We don't live in clinical trials. We go about our business. We are on all types of different medications. We are in different environments. We may be exposed to various variants. And this is my analogy to efficacy versus effectiveness. So the efficacy is kind of what you get from your internet provider. And I can't call any names now because my internet is pretty good now. But it's what you get from your internet provider. That's what you pay for, that you pay for your high-speed internet. Effectiveness is what kind of service you're getting in the room that I am in, for instance, based on bandwidth and whether you're behind a door, whether the walls are thick. It's the actual speed that you're getting. So of course, you want a good internet provider and you want a good package because you want high-speed internet access, but that means absolutely nothing if everywhere you go in your house, you're getting drops in your internet connection. So the internet is not effective. And how does that relate to vaccines? You could have a very efficacious vaccine in the 90s, for instance, that may not be as effective because the real population behaves differently. It's exposed to different variants, and perhaps it may have better coverage of those variants. Remember, when we compare efficacies, we're comparing apples and not even oranges, but breadfruits, because you have different time points, you have different populations, and all that we're saying with these percentage numbers is, look, this drug works and it's above 50% and it can be licensed, but we do not know how effective it's going to be until we give the population and see what happens retrospectively over time. So why get vaccinated? Because I've been asked this question several times. If it's not going to stop me from getting the disease, why get vaccinated? Well, why wear a seatbelt and use an airbag if you can still get an accident? It's really to prevent serious injury and death. Of course, you have to stop speeding and you have to watch your distance between the vehicle in front of you and behind you. Those aren't thrown out of the window, but seat belts and airbags save lives. You may be injured, but you're going to be alive. And that's all a vaccine bar is set to. Is it going to save my life? Or is it going to prevent me from getting seriously injured? Well, the last question I'm going to ask is, do we have time? Do we have time to kind of vaccinate at 10% now and maybe at 10% of the population a year from now? We don't. There is a global wildfire that is currently in progress. The only way that we can out this wildfire is if it's completely soaked with water. The type of water used or the vaccine can be fine-tuned, but we really should not be at the point of arguing what brand of water is most efficient. We just need to soak the fire. And so I echo the words of my colleagues around the world who are involved in vaccine science. The important thing is to get a safe and efficacious vaccine that's available near you and get vaccinated, because any immunity is better than no immunity. And I will close here and look forward to the questions.
Okay, thank you very much, Dr. Connell. That was quite an interesting presentation because I think the point of the efficacy versus effectiveness, I think that is an issue we want to hammer home. Because one of the questions that I have been getting is that in the region we are using right now in Barbados and other parts, we have AstraZeneca, which has a lower efficacy. But you're saying efficacy is one thing, but it's how but when the vaccine hits the ground. So it's like if you have, so we always say, you have a plan, but once your plan hits the battlefield, it begins to fall apart. So effectiveness is actually how it works on the battlefield.
That's right.
Okay. So Karen, any opening remarks from you this evening before we open it up to the panel and before I throw out some of my questions?
Good evening, all. Thank you so much. Just a few opening remarks. PAHO has been working assiduously with the countries in the region to ensure that they are prepared for the deployment of the COVID-19 vaccine. A lot of times people on the ground just assume, oh, you get the vaccine, you bring it in and you can just deploy. A lot of work goes into ensuring that when vaccine does land in country, that you have all the logistics in place to ensure that the vaccine goes from that freezer or that fridge into arms without any loss of viability. And it goes further than just the logistics. It goes towards who are we looking to vaccinate? Who are the persons that are most vulnerable? Who are the ones that are most risk for severe disease? And we know we have those who are at most risk, and those are the ones who we have been targeting in all of the countries. And that includes the elderly, the healthcare workers and the essential workers who are on the front lines, and persons with chronic disease. these persons are ones that we wish to vaccinate first because they're the ones that are most at risk. But after we have vaccinated those cohorts, then we can look at vaccinating other members of the public. The other thing that we have to look at is vaccine safety. So even as we vaccinate persons in the real world, as we heard Dr. Connell speak about, we have to monitor persons to ensure that any effects that they get from the vaccine that we document, and that we continue to observe and ensure and look at all of the risk and the safety profile of the vaccine as we roll it out in each and every country. So that's just a few words that I want to say and make sure that we get said this evening, and I am here available for any questions.
Okay, so I'm gonna start. So first of all, I see a question in the chat coming out of Grenada. Is the AstraZeneca vaccine currently used in the United States? Can anyone speak to that, whether the AstraZeneca vaccine is currently used in the United States?
I can
Currently,
speak.
we are using the Pfizer and the Pfizer BioNTech and the Moderna vaccines.
Okay, and do we have any sense of why or why not it's not being used in the US?
You know, Dr. St. John kind of alluded to how Dr. St. John alluded to how these vaccines are procured. The Pfizer and Moderna vaccines were the first ones that were approved, and facilities were here that could keep them at the sub-zero temperatures. And so those are the ones that have been rolled out. And if you went to the CDC website, you will find any information that you want about those two vaccines. So you can go to cdc.gov, and if someone is interested in what is happening here in the US. But I believe AstraZeneca.
Sorry.
Go ahead.
I was saying it's my understanding that there was a significant investment made with these two companies. And after today's decision, there will also be a significant investment made with Johnson & Johnson. AstraZeneca is being used by COVAX, the Korea, and also the Serum Institute of India for other regions of the world. So I think it is a matter of the advanced purchase of the ones that were furthest along in terms of production and also being able to be approved.
Okay, so
let's not forget, just 1 minute. Let's not forget that AstraZeneca is used quite a lot in the UK. And again, that was again what the UK also invested in. So AstraZeneca is used quite extensively in the UK.
Yeah.
So what I think I'm hearing from the panelists is that particular countries would have used their resources to order a significant amount of vaccines from a particular provider.
Absolutely.
And those funds are sort of tied up with that provider.
Well, let me also put another spin on this, because yes, you can invest in a particular internet provider as well. But if you realize that there's another provider providing a better service over time because you now have that data, you don't have to stick with the same provider. So countries may have an early allegiance to a particular brand or vaccine. For instance, in the United States, AstraZeneca is now being in clinical trials there. And if it is seen, not just in the US, but around the world, that the effectiveness of the vaccine is higher than the other two, then of course it makes sense for a country to change their provider.
Okay. I have a question coming here. In the event that someone takes the vaccine, then gets very sick after, who would be held legally responsible? Did you get that?
I would defer to the physicians.
I'm asking Dr. Broome if she wants to take it or if I want to take it. Or she wants me to go first. Which one?
It doesn't matter to me. You can go first and I will follow on.
Yeah, okay. So let's define very sick, because the AstraZeneca, and it is my understanding that most people got more of a reaction with the first dose of AstraZeneca, whereas with Moderna and Pfizer, they got more of a reaction with the second dose. But some people had fever, muscle aches, headaches, chills, vomiting, diarrhea. And if that is the definition of very sick, that's just a rather robust immune response. There are other definitions of very sick, and these include neurological symptoms, etc., etc. And CARFA has been tracking the reporting of this all across the world. And the percentage of really serious effects has been minuscule compared to mainly pain, fever, pain at the injection site, some body aches, and so on. So I think I need to hear the definition of very sick, because
Okay,
Barbadians
but you know, any person's concern is that who is the legal liability?
So now I can let Dr. Broome take that one.
Okay, so the legal liability depends on the country that you live in or receive the vaccine in, because some countries have different legal frameworks. So you can have legislation that determines if you make a claim about a vaccine. Of course, all claims are investigated. Of course, all what we would determine as adverse reactions or effects of the vaccine are investigated. So it depends on the legal framework of your country. Some countries have compensation schemes. It just depends on what your country has put in place. So it may be legislated, it may be a compensation scheme, but you have to defer to whatever framework is in your country.
Okay, I have another question. Someone is asking, so by taking the vaccine, are we part of phase 3 of the vaccine trials?
No. So phase 3 of the trial is completed once you see the publication of efficacy data. In other words, does this product work? And actually, the bar for that is not as high as people think. People think, well, it has to be 90-something%. It's really just as low as sometimes 50%, as long as you have the differences between the vaccinated group and the control group, and you show that there's a reduction in whatever parameter by 50%, then that drug is thought to have efficacy. And that's all that's required for them moving in to be released as a vaccine that is efficacious. And although we see now vaccines in the 90s, Dr. Broome and Dr. St. John would know historically, these are novel numbers for efficacy for vaccines. We have not seen these numbers before, and it possibly has to do with the type of platform that's being used in the mRNA and the viral vector in the mRNA vaccines. But guess what? Even though we are seeing this high bandwidth advertised by the internet provider, we still do not know what the reception is going to be in real life. So we still have to wait and see, will I be getting a lot of drop signals? Will my video freeze? So we need to know how effective these vaccines really will be.
Okay, so again, to be clear for the person with the question, the phase 3 trials have been completed. All the vaccines on the market have successfully completed those trials, and they have met the normal requirements for a vaccine to be released to the public.
And we are now in post-release surveillance.
Okay, so I have another question here.
That's why for people like CARFA, the approval is so important, because we know it's gone past the clinical trial phase.
Okay, so I have a question here. What is the rush? would it not be better to see how the vaccine was working in other countries? Many European countries have discontinued the AstraZeneca vaccine.
I really want to comment on that because it speaks to one of my slides. And let me see if I can get it up. So this is the rush. There is a global forest fire occurring. People are dying, infections is spreading, variants are evolving, and the vaccines that we have now, or we know, are pretty effective or efficacious against death, for death and serious illness for the variants that we currently have. But we don't know what's going to happen in the future. The longer this forest fire burns, the more likelihood more variants will emerge, and some of them may escape our vaccine technology. So the answer is, not only do we not have time as a country or region, but the world does not have time. The world has to concentrate on outing the fire, not slowly, but as quickly as possible. And that is a major tenet in vaccinating, global mass vaccination. You have to do so quickly because we may pay the price if we don't.
If I could add here as well, a lot of times we talk about, I love the analogy of the fire burning, but I don't know if persons realize what are some of the casualties in this pandemic. I know that persons hear a lot about the economic impacts. I'm not even talking about that. I'm talking about health impacts. I'm talking about the effects on our routine immunization. I'm talking about the overwhelming of the hospitals, the inability of persons to get routine procedures done, the inability of persons to get their cancer treatment, the inability of just routine services because everything is focused on COVID. So there are great health concerns that come along with this pandemic, which is taking all of our precious health resources. And we must consider these and the implication of these consequences when we think that we can just write it out, or we think that if we wait, it will get better. It won't. And we are feeling those effects all now.
I'm so glad you said that, Dr. Broome, because a few months ago, I was in the emergency room at our hospital with a group of junior doctors, and one said to me, well, thank God we're not really seeing the effects of COVID. And I said, well, look around in this emergency room. The hospital has just declared they cannot accept any more patients. We are surrounded with heart failure. Why are we surrounded with heart failure? These are people who have rationed their medication, who've delayed access to care, and we're now seeing this tsunami of cardiovascular diseases presenting in what is usually a quiet month because of COVID. So we're seeing the effects every day in our health system.
Okay, thanks for those responses. So we don't have time. The fire is raging. We need to get this fire out. Okay, I have another question here. Is the vaccine a one-time immunization, or will it be like the yearly flu shot? What is the best guess on that at this point in time? Is it going to be a one-off shot, or are you going to have to get that jab in your arm annually, like the yearly flu shot?
This is part of the reason why we shouldn't be waiting, because the vaccines that have been developed were developed with a certain level of variance around, and the more we use it and spread it, the more we're likely to suppress the development of variants and the cross-reactivity of variants. I was hearing about an immunocompromised patient who had a variant mutate and cross-react with another variant within his body. And it was really touch and go to try to keep him alive. We are hoping that this will not be the case, that it will become a yearly or every 2 years vaccination. But we do know the paradigm of that through flu vaccination. And we also know the paradigm of boosters, where every 10 years or so with yellow fever in the past, or every 10 years with tetanus toxoid, we would have boosters of vaccination. So the paradigms which may develop are not unknown to us, but we're watching how it's happening now in this early phase.
So the answer is right now we don't know. It's still too early in the process. Okay, I have a question here which I'm gonna direct to Michelle Reese. How should governments go about addressing genuine concerns about the vaccine while simultaneously addressing the wave of misinformation / conspiracy theories surrounding the vaccine? Michelle, let me repeat. How should governments go about addressing genuine concerns about the vaccine while simultaneously addressing the wave of misinformation / conspiracy theories surrounding the vaccine?
That's a very good question. One thing that we have to understand is that in this COVID-19 pandemic, all forces need to come together to deal with this. And we cannot simply rely on governments to address the problem. This is one of the reasons why we are here.
Absolutely.
Again, as I always say, clear, accurate information to allay the fears of the people in a general sense. But some people will be asking very specific questions about I'm pregnant, or I have heart disease, or I've had other allergic responses to vaccines. Those very specific questions are questions that they should address with their primary care physician. But governments have the very delicate job or difficult job to balance not only misinformation and disinformation, but they're also balancing things like the economy and so on. What can they do? Consistent, clear information. You know, on my PowerPoint, I talked about transparency. Just keep telling the people what is the correct information. You know, people are spreading things on Facebook and Instagram. And when you start sharing that stuff, it gets momentum. And sometimes that's the only place people go for their information or for their news. So we have to find all avenues to combat that. And it's not just a job for the government. Those of us who have accurate information need to get it out there.
Okay, now another question. What if there isn't sufficient take-up of the vaccine? Is it likely that the vaccine will be made mandatory in the Caribbean? Anyone care to comment on that? That in the event that there isn't sufficient take-up of the vaccine, do you see it likely that the vaccine may or may not become mandatory in the region?
I can't speak for Caribbean governments, but I can tell you that here in the city where I live and in some other places, mandatory vaccination has always been a difficult discussion. But some healthcare facilities will say that if you want to work here, then you have to get the flu vaccine, or you have to get the flu vaccine if you want to work here. I don't know that that is happening with the COVID-19 vaccine at this point. So I don't know if mandatory COVID-19 vaccines will be a way to go.
Okay, I mean, I think the issue might arise maybe with travel going forward, that might be an issue where some countries might require it.
That's what I was going to say.
Yeah, but mandatory vaccines for their citizens who may not be traveling or who just want to be there. It's different altogether.
Yeah, it's quite different.
There's special considerations.
How can you make something mandatory that is not equal in access to everyone around the world, or is not even in the supply for the 8 billion people that we have in the world? The attempts to make a vaccination mandatory for certain activities, especially commercial activities, is something that I think we need to prepare for. And from the ethical perspective, recommend that this is not approved.
And I don't think we're even at that point of the conversation as yet, because as you said, the access in many countries isn't there. But I think we will get there in months, years to come. And in special conditions, for instance, will healthcare facilities require it? We already know the clinicians on this panel, many of us are familiar, even traveling to, as medical students, we had to show proof of immunity to various conditions before you were even accepted. And you're not even part of that institution, you're just going as a visiting student or doctor. So it's not unusual. But it would be interesting to see moving forward how countries legislate this. And it really would depend on how well we out the fire, because if the fire is completely out or just simmering in some small points in the world, then it probably is not that important, because you have a sufficient population that has the herd immunity effect that you don't have to mandate these things.
Okay, I mean, I think it's actually an interesting issue which can have significant public policy implications going forward. So I think, again, in responding to that person in our audience, I think issue one is that the availability of vaccines in many countries at this point is so limited that the issue of making it mandatory at this point seems unlikely. However, as the vaccines become more available, that could very much become an issue. And also there certainly will be some commercial incentive to do this. I mean, I could see a restaurant trying to advertise that all my staff are vaccinated, so this is a safe place to come. Absolutely. And so on.
Yeah.
So that's going to be a significant public policy issue going forward that Caribbean countries have to certainly look out for, because it will become an issue as the vaccines become more accessible. Right now, access doesn't make it that much of an issue. I have a question here, which maybe is coming at Dr. St. John again, and maybe the role of CARPHA. With the reports coming out of South Africa that the AstraZeneca Oxford vaccine might be less effective against the COVID strain there, do we know the dominant strain in the Caribbean? And do we know, or have we thought about doing any bridging studies to ensure that the AstraZeneca Oxford vaccine will be effective in the region, particularly in the context of high levels of vaccine hesitancy in the region? So I think the first question I might want to ask, do we have any information on what is the dominant strain of COVID in the Caribbean and what strains are present here?
So in December, we started in collaboration with University of the West Indies St. Augustine campus doing genomic sequencing. And our 26 member states have been invited to send 10 samples per week for sequencing. So we know the strains that are circulating. There are many, but the 3 variants of concern, UK, South Africa, and Brazil, they're all checked for in the samples that we get. We've only detected the UK variant at present, but there are other strains that really are not of concern in that they are more transmissible or more virulent.
Can I just respond to the South African comment, because it's come up so many times? What the South African data did show is that the AstraZeneca vaccine was still effective in preventing severe illness and death. Mm-hmm. But for whatever reason, the South African government decided to pull the vaccine. Now, if you have a choice of vaccine, I guess you have that option. You can stop a vaccine and use another one. But it also raises another interesting question. Where is the bar set for vaccines? The bar for vaccines is not kind of, it will stop you from getting even the slightest sniffle. Because if the COVID-19 virus was only causing mild illness, we wouldn't be having this conversation about vaccines. There'll be no need for a vaccine. You kind of just get over your slight illness. The fact that it's causing death and severe illness is why we have a vaccine. And I think that the South African pulling of the vaccine in many quarters is considered might have been a bit premature, but we can't really dictate to a country when to pull or why to pull or when to restart. And perhaps this might come in times, in a few months, AstraZeneca is restarting in some parts of the world that it has been pulled.
And if I can also add as well, it is important that we realize that the South Africa study was of 2,000 people. That's a very small number of persons in a study. The other thing that the profile of the group, they were young people. And we know that young people are not necessarily those who are at high risk for severe disease, that we are looking at more the elderly and those with concomitant disease. So those things must be, you must bear those things in mind when you look at these, the data that comes up from studies and the decisions that are made while looking at the data.
For that population.
Again, following on from this question, and I know from the position of CARFA, PAHO, some of the UE persons as well, do we have any data on vaccine hesitancy in the Caribbean? How willing are people to take the vaccine? Because it certainly seems, from where I am here in Barbados, I think yesterday we crossed 25,000 people being vaccinated.
We've actually hit past 33. That was announced on the press conference.
So about 33,000 persons have been vaccinated in Barbados in a 2-week period. So certainly either we have a large number of early adopters in Barbados, or there isn't that much vaccine hesitancy. What do we know about the vaccine hesitancy across the region? Do we have any information on that?
Yes, I had in my presentation, in Johns Hopkins had done a survey which also included 2 countries in the Caribbean, which I will not name, and you were getting only 20-something% in one country and 40-something% in another who were saying that they would take the vaccine. That was in November last year. And this is part of the reason why we did the vaccine.
That's really low.
We're doing the vaccine hesitancy survey. And then when we finish that, we can analyze and give the current feeling in the Caribbean.
Okay, is it likely, another question, is it likely that the Caribbean region may have other vaccines available to us other than AstraZeneca?
Oh, yes.
And what might those be?
Anything that's approved, and there's some people who are thinking of buying vaccines that have not yet been approved. But anything that's approved, once you have the ability, and Dr. Broome can speak about that, to manage the sub-zero, you could purchase them once they become available. I don't think we're going to stop vaccinating this year. So we're talking about what's going to happen next year.
Okay, I have a question here, and maybe Joy, you are best placed to speak. Or maybe, is it a good approach by the Caribbean to depend so strongly on the WHO COVAX mechanism when COVAX currently is unable to provide sufficient vaccine doses to all countries to attain herd immunity levels, versus pursuing a more direct approach with the drug manufacturers, engaging in a forward purchasing agreement based on a larger volume purchase by CARICOM joining and buying together rather than individual countries buying themselves? So they are, I guess the person is asking, why are we going through COVAX?
I know precisely what the person is asking. Yeah. The pooled procurement of the CARICOM countries, even if we include Haiti, is not even a huge dent in the types of numbers we're talking about. So in terms of pooled procurement, the COVAX with over 190 countries with 20% of the world's population, that is a type of really strategic pooled procurement. I also spoke about the African Medical Supplies Platform. The continent of Africa is massive, and they are therefore making huge requests, millions, tens of millions of requests for vaccines, and that will help to lower the price. So the concept of pool procurement in the CARICOM region sounds great, but when we're talking about countries like India and China that can order millions, we can't, tens of millions, hundreds of millions, we can't reach there. So our prices, if we go even pooled, and there have been attempts, if we go to the vaccine manufacturers, we get quoted ridiculous prices.
Okay, so I think that's a pretty firm answer to that question. Now, as I look through the questions here, I am noticing quite a few questions that, and I think Michelle alluded to it. It would seem to me that these are questions that persons should have had answers from their doctor or a nurse, that from certainly their own physician. Does anyone care to comment maybe on the willingness of persons in the Caribbean to have this conversation with their healthcare providers? And parallel to that, the willingness, ability of physicians or doctors in a range of areas to speak to their patients about it. Because I mean, I'm seeing a lot of questions here.
Yeah.
Because we can't give medical advice on this panel.
Well, we
shouldn't. But a lot of the questions here, to me, should be answered in a discussion with their personal physician or healthcare provider, a nurse or someone like that. And I guess I'm trying to ask if anyone has any opinions or any insights as to why those conversations are not taking place. Is it something on the patient side that many of us in the Caribbean, we don't have a personal physician? We only go to a healthcare facility when we are sick. So there isn't someone we can have this conversation with. Or is there something happening on the healthcare provider side? How comfortable are a lot of physicians and nurses and other health practitioners advising their patients around the vaccine? I don't know if anyone cares to comment.
So I can comment on that because I think that both are accurate. There are barriers that are patient barriers, some that are physician or healthcare provider barriers, and some that are system barriers. The healthcare system is not meant to address wellness. In most systems, it's meant to address illness. And the doctor-patient relationship, although it's a special relationship, really is focused on addressing a problem. Remember, I started by saying vaccines are given to healthy people who don't have any problems at all, and they're trying to prevent having a complication of a disease which they're not sure they're even going to contract, right? And so imagine you're not calling your doctor's office to say, I have a headache. In other words, how can I fix a problem? You're calling to say, I have been thinking about taking the AstraZeneca vaccine to prevent getting COVID-19, although I'm not really sure I can get it because I'm doing all these other things. And that is a difficult conversation for a patient. It's also difficult for a doctor because, again, we are trained to respond to problems in medical school, except for public health practitioners, of course. We're trained to respond to a problem. You know, you have this, take this, you do that. I've received several calls. It has been a learning curve for me as well, thanks to my patients, about concerns about vaccines. And I've been alarmed at the amount of people who are now more comfortable in calling their doctor's office, at least calling me as a hypertension specialist, saying, tell me more about this vaccine, or you know my file, you know my history, should I take this? That is a different conversation. And even moving forward, I think as trainers now, for medical students, we have to have a conversation with our future doctors. How do you address wellness and disease prevention at an individual level and not at a more public health level?
So, for example, I mean, one of the questions I have, which I think is, I'm trying to wonder why this isn't happening with the physician. Hello, I would like to know if I have a mammogram schedule, is it safe to take the vaccine?
Right, and the answer to that.
Okay, so two things. One, does anyone care to comment on that question? And two, why isn't that conversation happening? Because there are a lot of questions in the chat like this.
Right.
Why aren't those conversations happening between the patient and the healthcare provider?
So the reason for that is, of course, breast cancer has been around a lot more than COVID-19, and we are more comfortable having a conversation about screening for breast cancer and having a mammogram than calling the doctor's office and saying, should I get a vaccine? Now, interestingly, this is not the case for all vaccine. Parents, for instance, will be reminded and will remind their healthcare provider, well, my son or my daughter is coming up for her X month shots. So that's because that's expected, but it's because it is not the norm to call about an adult vaccine, except maybe the flu vaccine. And we all know what the uptake of the flu vaccine has been. So it's not, so we have to change the whole doctor-patient dynamic so that patients feel a lot more comfortable in having a conversation about wellness. Now, with the mammogram, this is an easy one, there's no contraindication. So you can have your vaccine and have a mammogram done. There's nothing being injected from the vaccine that will distort the mammogram image, or certainly the mammogram is not putting you at risk for a vaccine side effect or adverse effect. Which I want to actually respond to. Michelle had thrown that question out to me. So the adverse effect is unintended. A vaccine should not cause you to break out in hives, lower your blood pressure, and almost collapse or have some kind of severe allergic reaction. That's an unintended effect, and it's an adverse effect. Vaccines, however, trigger an immune reaction, and as I believe some of us said last week, including myself, or this week, a robust immune response is an adverse, is a side effect, but it's not an adverse effect. It's a side effect. So you might have a fever, you might have some muscle aches, you might have some lethargy, you may even have a change, believe it or not, because some people get worried about this with COVID, you may have a change, a loss of taste because you're getting these symptoms. It's a robust immune response. So let me just say that this viral vector vaccine, AstraZeneca, seems to produce a fairly robust viral immune response in younger people. As we get older, the immune response is not as robust.
Mm-hmm.
Okay, I mean, I have an interesting question in the chat here, and I don't know if anyone might want to hazard. Now, most of us in the Caribbean, when we travel, we tend to travel to the United States. That's our closest sort of place to go. If we are taking AstraZeneca here and the US requires a COVID vaccine, would that mean you have to take a different vaccine to get access to the United States? Does anyone sort of have a view on that?
I don't think there has been a decision on this as yet, but I can say that I think that it's going to be very unlikely. I think what countries will require is that you have some proof of vaccination. In other words, you are not entering the country without immunity. And why is that important? I know we've made the point about severe illness and death, which is important for the individual. But think about the country now. If you were to go to another country and you did get infected, if you do not get severe illness and you do not get severe complications of COVID-19, you are less likely to transmit the virus as well. The AstraZeneca data, for instance, is showing early that it also decreases transmission. So at a population level, immunization is working to reduce transmission, and that's what the country is concerned about. It would be very unusual and unlikely for a country to specify what type of vaccine you should have had to enter. Maybe in the future, who knows? As for some other conditions like hepatitis and chickenpox, for instance, proof of immune titers might be required. I hope not, but if that is the case, then those tests will be available and we will probably all have to provide evidence of that.
Again, so thanks for that. So again, in light of a lot of the questions that are coming, people seem to have concerns about their own conditions or someone they know. And is it safe to get the vaccine? A question I would ask, are you aware of any conditions, any particular health circumstances where you would say definitively that person should not take a COVID-19 vaccine?
So I think this goes for any vaccine, but for instance, if someone is acutely ill, for instance, if you might have a bad flu, now that's not a good time to go and get a vaccine. Or if you have a presentation of a flare-up of your lupus or your ulcerative colitis, or you had an episode of heart failure, you're not going to go and get immunized in those acute situations. So you wait until your body is at its best.
What if you're on chemotherapy?
Yeah, so I was going to mention that. I was going to mention chemotherapy because that is an immunosuppressive state. However, you know, the risk of taking these new platform vaccines, the mRNA and the viral vector vaccines, is really that you will not mount a sufficiently robust immune response. Remember, I was talking about the fact that I was out for 2 days. So you may not mount that response. That response is important. We have heard, for instance, some medical experts going as far as saying, if you can really bear it out, don't take things like Tylenol and Advil and those kind of things around the vaccination period. Let the immune response come forth, and if you can manage it, just kind of wait out the tide as it goes along. So those patients on chemotherapy, the risk in the past was that we were using live attenuated vaccines that had the potential, for instance, of causing problems. But this is not a platform that's being used in the currently available vaccines.
Okay, so one of the questions that I have been getting is about the differences in the prices of the vaccine. So I'm gonna share my screen quickly, just maybe to highlight some of the latest information we have in terms of the cost of the vaccines. So we have the Moderna, that time, and this is in US dollars, 37, the Sinovac at 30, Pfizer, BioNTech at 20, Sputnik 10, Johnson & Johnson 10, and University of Oxford AstraZeneca at 4. And in responding,
this is out of date for the for what is being quoted now through the pool procurement of COVAX, at least.
Okay, because one of the points I've been making to people who have asked me that question is also the price of a vaccine, the cost depends on many functions. It depends on a lot. So for example, if you have a company like Moderna, which is in terms of pharmaceuticals, is a relatively small company. It does not have a large pipeline of products. So for that reason, their price is likely to be higher than the price of a much larger company that has a larger pipeline of products. Also, the nature of the production process is a key factor in cost and price. So most persons may not be aware, but a large percentage of all medicines in the world are actually manufactured in India. The fact that you can have the production in India significantly reduces the cost. So the fact that like the Moderna and the Pfizer, the fact that they are not being done in India would have an effect on their cost because the cost of production is relatively higher. So the differences in the prices of the vaccine depend in part in terms of the cost structure of the different companies, where they are producing, the size of the companies, and in terms of their own internal dynamics. So I've been saying to people, don't read too much into price in that sense, that they're really reflective of unique features that affect particular companies. And as Joy was saying, those quoted prices are averages that are out there. Different people are actually getting quite different prices. Okay, so I wanted to respond because I've been getting a lot of questions and say, okay, why are these vaccines costing so much difference in price?
Right.
A small company like Moderna, really, this is actually their first product that they have gotten to the market. They don't have a large pipeline of drugs. So the cost of theirs is likely to be higher. A company with a much broader pipeline, a set of drugs, the price is likely to be lower. If you can manufacture your drug in India, it's lower. Again, the whole cold storage, that again increases the cost. So there are a whole set of factors that determine. I have another question.
I want to respond.
Sorry.
Okay, so let's take Ken and then Joy.
So I just want to respond to a comment in the chat because I think it's credible. I mean, is there any information on Cuban vaccine, which has a high efficacy?
Okay, but Ken, before you go to Joy, did you want to comment on that price thing? before we move on?
Those prices may be low compared to what individual countries in the Caribbean may be quoted, because they may only have a couple 100,000 or a million or so. So that higher price is very much pushed when countries go individually, or even groups of small population countries go to these manufacturers. So this is part of the beauty about COVAX. But I was asking to answer a question that Malcolm Grant has asked again this time. But I do know about Cuban vaccines.
Okay, so let's take the Cuban vaccine, because there's a question there. Is there any information on the Cuban vaccine and in terms of its efficacy? Does anyone want to comment on that?
Right, so I was going to say, to my knowledge, the Cuban vaccine up until February 21st had not completed its phase 3 trials. So therefore, you can't say it is more efficacious, because the phase 3 trials are testing just that, efficacy. So as Abram Weeks has just stated actually in the chat, it's currently in phase 3 trials, and we will await those phase 3 trials for efficacy. And then once it's efficacious, then it comes a regulatory framework where these results, the manufacturing plants, and this is not just for Cuba, for wherever the vaccine is made, it has to be reviewed independently by a body like WHO, for instance.
So the Cubans approached CARPHA, and they actually detailed us about the Cuban vaccine this week. And what they said is that they haven't gone into phase 3 trials as yet, but they gave us quite a detailed description of the vaccine, how it is made up, how it is being tested, how they plan to actually conduct the phase 3 clinical trial in the future coming up, the regions in Cuba where they plan to conduct, and so on. And so we have asked them to keep us updated on this so that we can actually keep it in our tracker, because we've been tracking the vaccines that have come up. I'm doing this because we know that there is a great deal of interest and expressed desire to utilize the Cuban vaccine. The Cubans have really endeared themselves to the Caribbean population with the support that they have been giving in the countries. So I was very glad that the Cubans came to speak to us and gave us those details. So that's the latest. That was this week.
And hopefully we can get some
Joy,
results.
Yeah, and Joy, so I'm gonna ask you then if you can respond to my countryman, Dr. Grant, on his question, Malcolm Grant.
So CARPHA and PAHO have recently agreed to work together on our communications plan. And as I would have said before, we have been distributing these surveys to find out vaccine hesitancy. We want to do surveys in all of our member states and then analyze all of it. I saw a preliminary report on what we have been able to get so far. So based on the information that we get, then we can work with PAHO and tailor make the communications campaign to suit. In terms of setting up a unit, Malcolm, CARPHA is not that rich. So what we will do is our comms unit will work with the PAHO comms unit. And there's also the CARICOM Secretariat Communications unit that we've been working with and plan to work with. And then, of course, there is a regional health communicators network, a focal point in each of the 26 member states that we work with very closely so that there's a commonality and a certain standard to the message. And then, of course, they're also being translated into languages and dialects.
Okay, so we are coming into our last 5 minutes. So what I'm going to do is to ask our 4 panelists to give their closing remarks, your closing comments. What message do you want to leave with our audience here tonight? Karen, we start with you.
Okay, so I want persons to trust in the WHO, the stringent regulatory authorities, the Ministry of Health personnel, that the vaccines have been rigorously tested by the manufacturers. The stringent regulatory authorities have rigorously analyzed the data, all of the safety aspects, and have approved the vaccines for use. Safety monitoring continues, even though the vaccines have come out of stage 3 trials and come into the public, safety monitoring continues. But the only way that we're going to stop the hospitalizations and the death and the effect on the economy and the grinding to a halt of our daily activities, the norms, these things we used to enjoy, is by getting the vaccine personally, as a family, as a community, and as a population.
Thanks for that, Karen. Michelle?
I have a question.
Yes, go ahead.
Do we have to stop right now?
Well, we stop at 8, so we're into the closing remarks, but you can have a privilege as a question as a panelist.
That's fine. The bottom line is these vaccines save lives, as Dr. Karen Broome just explained. We are in a situation where currently, perhaps, I don't know if it's half of the vaccines available to people in Barbados have been given, if they want to keep that batch for a second dose. So we can breathe and take some time to continue to get our questions answered. Over, what was it, 30,000 people have received?
33 out of about 45.
So,
Because the second dose is being kept.
Okay. So
that's what the Prime Minister said.
Okay. So we're going to rush to get the vaccines. We want you to make those appointments, but don't give up and don't get tired of the waiting. Some people have had, I have read that some people are complaining about the long wait to get a response. That is actually a good sign in terms of how many people are trying to get the vaccine. And so we should try to encourage people to keep doing that, but be patient. The vaccines will come.
Okay, thanks for that. Dr. Connell?
So I would close by saying that two things. Vaccine trust is justified because we have clear clinical trials that can be accessed, dissected, consumed by the general public, and interpreted in order to make an informed decision. You also have some vaccine skepticism, which is also justified because we know the history surrounding vaccines and that fear will always be there. The public now has to really balance on a scale quite fairly to themselves and to the population and to the world. Which risks am I willing to accept? Am I willing to accept the risk that I think might be there in any intervention, regardless of how small it is, like a vaccine? Or do I accept the risk that if I get infected, I could get severely ill and die? And it's balancing that risk, because removing a vaccine and saying I'm not going to take it does not remove the risk of a severe complication from COVID. So you can't get both sides of it. So you have to balance the risk, have discussions with your healthcare provider, and decide whether which risk am I going to accept and live with.
All right, thanks, Dr. Connell. And from the panel, Joy, you have the last word from the panel.
Really, I didn't realize it had got to that. I want to say how proud I am of the Barbadian population who have persevered and allowed the achievement of, I posted on Facebook yesterday, heretofore unseen achievements. I also want to salute the nurses. Retired nurses have come out, as they were telling me on Facebook, bend the back, hurt the knees to get this to happen. I want to say that I am also proud of public health. People don't understand the field of public health. This is what we do. We save lives at the population level through prevention. And what has been happening in Barbados has been one of the best examples of it. We cut through all of the hesitancy. We cut through the annoyance at waiting and the logistical issues, and we just push in. Women given 300 vaccines a day on their own, day after day after day. This is amazing, and I feel so proud of this. I want to see this duplicated across the Caribbean. The Caribbean Public Health Agency has seen us go through this so far with little illness and death. We're starting to get upticks in the illness and death. And we need to stop COVID from taking root in the Caribbean and the variants from taking root in the Caribbean. And the vaccine is what is going to save us.
All right, thanks for that. So again, all that is left for me to do is to thank our panel of experts for taking time from their busy Friday evening to come and share their knowledge with us. And I also want to thank the members of the audience, because without the audience, there is no panel. So again, I want to thank you for joining us. I hope you found the panel useful. We at the UWI, we are here. We are not here to sell you anything. We are simply here trying to provide you with the best science and the best knowledge around this topical issue. So again, have a good evening. Stay tuned for future panels from the K-Field School of Business and Management on interesting topics. Thank you very much and have a good evening.
Good evening.